Renal cell carcinoma, or kidney cancer, is among the top 10 most common cancers in the U.S. for both men and women. The most common treatment option for renal cell carcinoma is nephrectomy, removal of the tumorous kidney. If possible, patients undergo partial nephrectomy, also known as kidney-sparing surgery, where the surgeon removes only the affected region of kidney, leaving as much healthy tissue behind as possible. 13,000 of these partial nephrectomies occur annually in the United States. While some patients recover fully, post-surgical renal function in others can decrease and ultimately can lead to long-term renal failure or chronic kidney disease. About 10 to 15% of patients who undergo partial nephrectomy end up with chronic kidney disease. This percentage contributes to the huge financial burden placed on the Medicare system worldwide. 28% of Medicare spending goes to treating chronic kidney disease. Per patient, the government spends about $72,000. Therefore, finding a solution that could reduce this percentage to less than 1% would save the medical industry $9.3 million. The cause of post-surgical renal failure comes from the current mechanism in place to prevent blood flow during the surgery. During partial nephrectomy, surgeons clamp the renal hilum, the main blood supply to the kidney, to prevent patient bleed out and improve visibility by eliminating the amount of blood in the operating region. This clamping technique is currently the standard of care for partial nephrectomy. This is a problem, however, because when clamping this main blood supply, the kidney undergoes ischemia and does not receive sufficient oxygen or glucose necessary for cellular metabolism. As a result, even healthy cells undergo ischemia and cell death if they are deprived of blood for longer than about 25 minutes. Because of this ischemic time constraint, surgeons are put under pressure to complete the procedure as quickly as possible. If the cells begin to die before the surgery is complete, studies have shown that renal function, measured by glomerular filtration rate, decreases, which can lead to further kidney cancer. If the filtration rate drops below about 15 milliliters per minute, patients will go into renal failure. A solution should target those with lower renal function to begin with, and in particular those who only have one kidney and therefore cannot spare any additional loss in renal function. From these observations, we realized we needed to find a way to limit ischemic damage in non-affected portions of the kidney in patients undergoing partial nephrectomy to improve renal function. In open surgery, there are various mechanisms in place to prevent ischemic damage. Surgeons use Kaufman clamps for tumors on the poles and sometimes even use their hands to squeeze the kidney itself. These two procedures, however, are impossible in a laparoscopic surgery. Therefore, in the past 10 weeks, we have developed a tool that clamps the parenchyma of the kidney itself but can be implemented laparoscopically. Others have tried to create similar tools, but those who have developed laparoscopic techniques have only taken into account tumors at the poles. With that, we introduce the Perrin clamp. Our clamp enters the body straight through the laparoscopic port. Once inside, it curves and proceeds to clamp around the affected kidney area. The Perrin clamp will benefit patients, urologists, and insurers. Patients will undergo a safer procedure, urologists will have less time pressure, and insurers will have lower long-term costs. The Perrin clamp will change the way laparoscopic partial nephrectomies are performed, affording surgeons significantly more time by localizing and minimizing ischemia. The curvature of the clamp and the position of the shaft leaves the surgical area unobstructed. The radius of the curvature of the clamp will be approximately 4 centimeters in order to encompass the majority of tumors. In order to bring this clamp to market, we first need to solidify a design that can be used in the operating room. Next, we need to create a 2-scale model with the appropriate material in order to confirm that we can provide the adequate force to the kidney. After testing our final prototype on living pig kidneys, we hope to conduct preliminary clinical testing. Finally, we hope to apply for FDA approval so that we can see the Perrin clamp help patients recover across the country.